is such a pleasure to be here, and there are things that I really like about the setup of this talk and things that I don't like so much. The thing I don't like so much is 30 minutes, because I always like to talk a long time. But I love the informality, and I want this to be an informal talk. Just know that if you, and you're welcome to interrupt me, just know if you interrupt me, I get extra 2 minutes on the timer for every question. Juliana and Taylor told me about the purpose of this kind of talk and the audience, and I just want to check on the assumptions. So, how many people in the room are affiliated with the medical center? That's good. And of the people affiliated with the medical, all right, a little podium. The people affiliated with the medical center, how many of you are actual clinical providers? Okay. Sorry for you. So I actually changed my talk today, because I was giving talks that were really oriented towards clinical providers for the past few days, but this is really going to be a research talk, which I'll go right to disclosures and disclaimers with that. So first of all, just to disclose, I am a consultant now, and I have some clients, but I don't think they're going to bias the talk I give. And a little bit of a disclaimer. What I want to do today is to, in this crazy time we're in, kind of share some thoughts and have a discussion about where is research at the Climate and Health Nexus going and going to go, so that you as a research institute can think about how you would adapt to what is really an incredibly challenging situation. And the disclaimer is, I spent a lot of my career, including the first 12 years in the federal government, in a research setting. I was the HHS principal of the Global Change Research Program, and I was at NIH. And I made a big pivot from the research world and the scientific assessment world, not that I was ever really a researcher, but the science and research world, to the more health sector policy world, and left research behind. So there is going to be perhaps a little inherent bias in my talk, because I'm speaking from a different place than I was. I was kind of in the midst of the research world, and now I'm more of a consumer of it. But I think that the bias that I have is actually a valid bias and reflected by what I'm seeing in the research funders and the kind of things that they're interested in. And hopefully that will be clear as we go through. So these are what I'm going to try to cover, and I want to give you a sense of what's going on in terms of the funding agencies. And there's going to kind of be two dominant themes. And one is that both the science and research and the policy at the complicated nexus of climate change and health is really focusing and broadening beyond thinking about atmospheric conditions and rainfall and even ecosystem change, and really getting enmeshed in social frameworks, social determinants of health, and the interactions between poverty, housing quality, energy security, food security, climate-related exposures, and health. And what does that mean, for an environmental institute? And the second is that there is a lot more awareness that the health impacts associated with climate change are often mediated by disruption of the delivery of services, and that people aren't the only receptors when it comes to climate change. It's also the health systems themselves. And so understanding the kind of health system level operations, disruption of operations is kind of a new area. Again, feel free to raise your hand and stop and question if at any point you have that question. We are at a weird time. I'm not going to spend a lot of time talking about this, but 2021 to 2024 was kind of an unprecedented time in the climate and health world. I've been at this a very long time. I got plucked out into this role in this office. That was my dream job. But it was in the context of a real sea change in my field. I mean, for 20 years, I could count on hands and maybe a couple toes, the kind of research leaders that were working on climate change and health. And it kind of inflected up in the 2010s, but 2020 to 24, the tent got huge, and both globally and domestically. And this was an unprecedented kind of sign. 2008, 2009, we had World Health Day was about climate change. We had people here, their leaders proclaiming it was a big deal. But to have 200 medical journals all write the same editorial on the same day was kind of an unprecedented show of real concern and commitment. And here's where we are now. I just had to couldn't do more than just quote that rising temperatures have been made by stupid people, and climate change used to be called global cooling. Yeah, okay, thank you. And environmentalists want to kill all cows. I thought that was important for the Gun Institute to be aware of that labeling of environmentalists. These are my inconvenient truths to set a little bit of context. The first one, I think folks here are aware, but there was really low awareness. 5 years ago, nobody talked or thought like this. It was really Jody Sherman and Matt Eckelman at Yale who did the work and raised the awareness about the importance of the health sector, not as a victim of climate change, but as a perpetrator, as a contributor to climate change. And it's related mainly just to the fact that it's so big and so much activity. It's really, the figures that they use are tied up to economic models, but there's just a lot of material that gets made and used and disposed of, a lot of movement of goods. And all of that means that the health sector, if the US health sector was a country, it would rank 13th. The health sector globally is, bigger than all but 5 countries. So you can't really think about solutions to climate change unless you think about the health sector as a sector. But we're still not there. The 200 medical journals, we're still not there. If you look at the major climate philanthropies that have sprung up, billions and billions of dollars to solve climate change, health is a message, health is a talking point, health is, of course, why we're doing this, right? Thank you very much. That's why you're doing it. Give us 1%. There is no investment or real deep recognition that the health sector, the climate environments are really kind of hands off the health sector. And, on the other side, health says we have many, many other things to worry about. We have to worry about access. We have to worry about poverty. We're worrying about Medicaid policy. We're worrying about physician reimbursement. We're worrying about nursing shortage. We're worrying about morale and burnout. Don't ask us to worry about climate change. That's an environmental problem. It's not a health problem. So there is a real problem at the nexus of climate change and health. For years and years, there has been recognition that health would be harmed. For years and years, the research is focused on endless elaboration of the mechanisms and the pathophysiology and the exposures and how can we measure the exposures better. A very public healthy risk assessment-y, which is where I come from. That's where I started, and I was doing that for a long time. But the climate health nexus, as we will demonstrate, is much richer and broader, and it's still not really well recognized. And then lastly, this is just all idiosyncratic coming from me, but if you look at the philanthropy and if you look at like Gates Foundation, right? What would you do if you had hundreds of billions of dollars? What does Gates do? It's like vaccines and tech solutions to climate has been where they've been for a long time. But we know that the problem is political. We know that we have the tech really, and that our biggest problem is the people. We're not investing in the people as much. It's just kind of an observation. I'm not going to spend a lot of time talking about the impacts, but it's pretty obvious. I just did a press conference yesterday, a second press conference about this administration's intention to rescind the endangerment finding to say that greenhouse gases, in fact, don't really harm public health. And we talked endlessly about the reams of the strongest possible science that our society can muster that say the opposite, but then we're all living it, right? I mean, you've been living it here in Vermont, from crazy floods that have been devastating to the wildfire smoke this summer. And the whole world's experiencing this. There were 14 unique, separate federally declared public health emergencies between 2021 and 2024. Heat-related deaths have really tripled since the 2010s. And we're seeing really devastating impacts on both hospitals and healthcare infrastructure. Like Hurricane Helene knocked out the plant that makes like 65% of all of the saline fluids for the country, which devastated, it had impacts in Vermont, it had impacts everywhere. Things that are at unprecedented levels. So there is urgency, obviously. This is one of those big slides with lots of nice colors and a ton of words on it, and a big framework. And I have a tendency to kind of show them and then kind of say, don't look at them too carefully. but this is really, really rich. And I show this because this is the only diagram, I haven't been able to make my own. I haven't had graphic support. This comes from the World Health Organization. But this kind of puts the climate health nexus all together. The biggest thing, it's the World Health Organization, so the biggest thing is a remake of kind of the standard exposure pathway kind of diagram that shows where primary climate change phenomena, lead to specific adverse health outcomes. And, the main things to just see there is that there's a lot of them. There's a lot of different hazards. There's a lot of different health outcomes. They are mediated by what the WHO is calling vulnerability factors and exposure. Vulnerability factors, I'm going to say, are kind of more. I find their list a little challenging, but I like to think of it in terms of things that are characteristics of the individual, and then things that are characteristics of built environment, society, structural issues. What they're calling exposure are things like energy insecurity, water, inadequate water and wastewater systems, challenges to the kind of systems that support. But again, just to reiterate that the people who are, we know that everybody is at risk, but we know that the people who are actually suffering are suffering because they are socially disadvantaged in one way or another, from lack of education, from marginalization because of gender, race, religious beliefs, from lack of education, from challenges in either being unemployed, unhoused, or inadequately employed and inadequately housed. And so understanding, and one of the things that I want to impart is that we know that pretty well. We don't need a ton of research anymore to say how much more at risk somebody is because they are low income quadrant, or because their house isn't weatherized. Where we are now is needing to gather data on that at a very granular level and start looking at interventions and saying, okay, we know that's the problem. Can we actually protect people in that state? What is the way that we're going to actually undo those adverse effects? Is it just weatherization, or is it weatherization plus energy financial assistance? Those kind of questions are what are coming out now. So that's why I'm sitting on this slide for a while. The really big thing about this slide is the bottom right. This is the only slide I've seen that shows that, yes, people are affected, people's health is affected, but it has that little two-way arrow there that climate change both has direct impacts on systems, as well as, when there's a severe heat wave or a severe flood, there's a surge of patients, and that impacts the operations of healthcare facilities as well. And then it has something that looks a little bit more like a trash to steam plant in a hospital there with a big old smokestack. But again, acknowledging that the health sector itself is a contributor. So health sector as a vulnerable system that we need to understand better, there's been a real dearth of research for that, and health systems as contributors and in need of looking at changing the way they provide care in a way that reduces their emissions and pollution, but does not adversely affect health outcomes. Any questions? I'm not going to spend a whole lot of time. This is another one of those diagrams with a lot of words on it. But this is one I'm just going to point to and just say, this idea that in order to understand how we're going to protect people, we have to understand the social determinants of health is incredibly relevant to the climate and health nexus. But the climate change world is just kind of pulling it in from the mainstream health equity field. There's like 10 times as much research going on health equity and the importance of upstream drivers of health. It's been going on for the last 20 years, completely separate from not recognizing that climate change had anything to do with that. And so part of the message here is we need to be fully integrating and mainstreaming the climate health as a social determinant of health within a sector in a field and a research community that's collecting that data and doing these analyses for 20 years, but not thinking about the role of extreme weather or other kinds of climate-related stressors. And I shared this diagram, which is nice puffy clouds around, a healthcare center with windmills around it, to emphasize that the sources of greenhouse gases from the provision of healthcare themselves interdigitate and are nuanced in an association with the social determinants of health. So one of the biggest contributors to the greenhouse gas footprint of a hospital is its food procurement service. Vermont is one of the leaders in having us, thinking about that and doing, looking at its procurement policies for food as a force of both social good in terms of supporting local economy, providing local employment, and also supporting sustainable regenerative agriculture as a source of their food. The transportation of patients and staff is, so the transportation policy of the community. So I just want to convey, and it complicates stuff, and it doesn't necessarily lead you to very clear, sharp pictures, but the questions that need to be answered are these questions at the nexus of essentials of providing care for people, the fact that it's 20% of our GDP, 10% of the employment force in the nation, and so huge source of greenhouse gas emissions, so that we have to have solutions that think about the local economies and make sense from an economic standpoint, and that optimize multiple parameters that are optimizing the thriving of a community, optimizing the outcomes for the patients who are sick, optimizing the cost minimization, because it's a huge issue in health, obviously, and optimizing the environmental performance. And again, just to drive this home one more time, and to say that this idea that a big hospital, a big healthcare system is enmeshed in the community and is a huge economic force. And we have to understand both the sociology, the provision of human services, the provision of food support and housing support and energy insecurity and food insecurity is not a new idea. It's an idea that also has come to fruition without thinking about climate change. So this concept of the hospital as this huge force has been dubbed, that hospitals are a type of critically important anchor institution in communities. People talk about hospitals and universities kind of as primary anchor institutions that have a mission of social good. So I just wanted to share this idea of this complex system where you have the hospitals providing all of these, influencing the well-being of people through all of these roles as purchaser, employer, as changer of the landscape, as owner of property. And all of this is going on without a thought to climate change, but climate change is impacting the food procurement. It's impacting the transportation in a major way. It's impacting, how do you manage your campus so that, you don't flood and you don't flood the community, et cetera. Make sense? So let's shift. I got 6 minutes, so I'm going to try to do this very, very quickly. In the past 5 years, 10 years, and more and more agencies within the federal government had come on board to fund climate and health research. A lot of times it was very hard to get funded by NIH. The NIH funding was very small and highly competitive. So a lot of people got funded by EPA or by NOAA, through very, very small grant programs. Most of these programs are dead in the water now. That is our reality. The research arm, the entire research arm of EPA has been fired. The funding of the climate health program at CDC is gone. The NOAA research programs are gone. AHRQ, with Agency for Healthcare Research and Quality, which was the only home for health services research. To understand that part of healthcare operations is zeroed out. NSF still exists. I don't know as much about NSF, but I want to say a little bit about NIH. So this is not the current website. You might understand. I was able to find this. It's on an old slide. I was able to find this. So NIH created a very, very robust and dynamic climate change initiative at the start of the Biden administration. Let me go back. And I'm going to share kind of the details of how they were thinking about the kind of research they wanted to fund. But the big news is that that program has basically morphed into the HEW program, Health and Extreme Weather. This is a current website. And my former colleagues have said that they are actually essentially funding the same grants that they were going to be funding this year, that the money is not gone, that they still have the money. NIH, is the most protected part of the federal research enterprise of all. It's always been a bipartisan and it's very protected in the budget. And so it is still going. This is the new cover of their Health and Extreme Weather Strategic Framework. It kind of looks like a climate and health one. This is the old model. And what I wanted to emphasize here, and it's not very clear. I don't find things like this especially useful. But you have to say everything's transformative if you want to get people excited to appropriate the funds for it, I guess. This strategic plan had a much bigger emphasis on interventions, evaluation of interventions, on implementation science, on being out in the community and having a solutions orientation. NIH is very much a mechanistic kind of basic research place, but this initiative really was saying it was going to do system science, adaptation research, dissemination, and implementation science. If you look at, this is their new framework, they had to have a different shape to make it completely different from the Climate Change and Health Initiative. It's basically the same. It's got this core, it's got intervention science right there, it's got training capacity building in there. It's swapped out some words, but it still has adaptation in there. Hopefully that doesn't get them in trouble, implementation science, et cetera. So I just want to make the case that NIH is funding, it is funding community engaged research, it is funding research that is trying to look at solutions at this nexus of social determinants, housing, food security, et cetera, and health. This is the other kind of big research framing that's going on in climate and health today. They've unfortunately dubbed it REACH, and it's coming out of the WHO, which makes me think of the EU and REACH, and it's very confusing, and their acronym doesn't even really work. As you can see, it's the research agenda for action on climate and health, but they wanted to call it REACH for some reason. I share this slide, just it's a big process. It's been going on for a while. Some of you may have been involved. It's a very inclusive process, tons of consultative workshops. They just did a big Delphi survey that I participated in. And these were their 7 areas, not in any order. They haven't prioritized them at all. But it looks kind of similar, right? It's looking at exposure pathways. It's looking at it in a health equity context. It's focusing on implementation science. And there's a lot of focus now, and this is, I think, really important for the GUND, on the economic aspects of this. What are the financial risks? What are the financial costs from utilization of healthcare services? We're at a point now where the case making has to get to a granularity of money, and it requires different kinds of data sets, and it requires different kinds of multidisciplinary teams. And then my last example of this is the Wellcome Trust. Wellcome Trust, you're probably familiar, is like become the biggest funder globally on climate change and health. They have hundreds of millions of dollars almost per year to put to it. They don't have anything open other than kind of career development awards, but these are just closed opportunities that they had. They're doing a lot more basic kind of stuff. They wanted to do something very basic on fungal adaptation. Again, as an environmental ecological institute, there are some really basic questions that are really big that have not been figured out. You can ask me questions. I won't talk about funguses right now, but it's something I think about. The climate change impacts on soil, we know very little about. It's kind of like the ocean. You get below the surface, and like we're just understanding how it is life supporting. There's real concerns about that, and then it's very much about the global scene. The EU in general is very focused on research that I'm a little bit skeptical of, frankly, which is endless research on how every other sector affects health and getting all the other sectors to change because we've told them that they affect health. I was really into that about 15 years ago. I've lost my enthusiasm, but that's still a big part of the research agenda. In closing, I'm just going to share something really quickly about our office. This was not President Biden signing the office. I don't know what he was signing there, but we were created by Executive Order 14008, and we did a lot of things in the office. I'm not going to take the time to talk about it. Happy to talk about that during Q&A. But what I wanted to close with was just one of the most important things we did was to really engage every piece, all the divisions of HHS. And HHS is the biggest agency in the federal government by money. It's 13 different agencies that are all kind of fiefdoms. They're all semi-autonomous. I had been trying for all my time at NIH unsuccessfully to get CDC, to get like FDA and HRSA and CMS to have climate change activities. We were finally able to do it. We came up with a strategy that had 90 actions among all of those divisions, which in and of itself was an accomplishment. But I just want to leave you on, this was our framework. This is an adaptation of, if you in the space, you've seen the WHO's Resilient Health Systems Framework. This is our adaptation of it for the United States. And the foundation, all of these things have to happen. We have a workforce, we have capacity and training and workforce development is critical. We're changing the way we practice medicine to reduce the greenhouse gases, et cetera. We have to retrofit and do technical assistance. You have to have funding, et cetera. But the core, the bottom of this is collecting the right data and having the right research to ultimately, in the health sector, transformation isn't going to come from people saying it's important. It's not going to come from people saying we're going to hell in a handbasket. It's not going to come from anything other than embedding these concepts into the currency of the realm, which is quality metrics. So that word measures there is a loaded term specific to the health sector of specific parameters that are easily measured that correlate with quality of the care, like better outcomes or worse outcomes. And so that's where we are right now. I just had a meeting this morning with another fabulous person from the Vermont Health Center world, who leads an effort called the Gravity Project to develop these kinds of quality metrics. They've been focused on social determinants of health, which is a piece of it, but we need them for, what are the aspects of healthcare delivery, sustainability, efficiency that we can say really make a difference. And we can't even really measure the resilience, the kind of pre-event resilience of a health system to be able to assure that it will continue operations through. So that's kind of another research gap that personally I think is where we are. The only people who really got this was the Agency for Healthcare Research and Quality. NIH doesn't, everybody says we don't do this, we don't do that, even though everybody says they should be doing that. And NIH does not do health services research. So the home for this may be a little hard to find, but that's the place where I think that will have the biggest bang for the buck ultimately. So bottom line, more applied research related to the business of healthcare, I think, is the new meaning of the climate health nexus. It's not just what are the health outcomes, but how do we transform the health sector. The federal government, if it, on the other side of this shutdown, funds any research, it will be research that will have different words for things, but these issues are related to climate change. They're not related to climate change, right? Like they happen, in a time frame that isn't a climate change time frame. The philanthropic and commercial sectors, the corporate foundations are trying to fill the gaps. They will not fill the gaps of the loss of the federal government, but that will be, I think that's where academic institutions have to turn, and hopefully only for a short time before the federal role gets restored. So thank you.